Hi, I'm Dr. Matthews. I'm here today to talk to you about cardiorespiratory fitness testing. So this is essentially one of the categories of testing that you would normally do before you allow somebody to engage in exercise under your supervision, so as a client of yours. All right, so a couple textbooks and chapters I want to point out here. So the American College of Sports Medicine's, or ACSM's, Resources for the Exercise Physiologist, the second edition, chapter 3 is a good read for this. In the American College of Sports Medicine's Guidelines for Exercise Testing and Prescription, 10th edition, and that's chapter 4 from that. So maybe go and read these textbooks alongside with watching this video in order to get a better understanding of the topic. And if you scan these QR codes, it'll take you to a site that's going to show you the textbooks I'm talking about and show you places where you can buy those textbooks. In the sequence for exercise prescription tests that we've been showing during each one of these videos, we are essentially on steps 6 and 7 if you exclude the height, weight, and body composition assessments, which we talked about in another video. All right, so we're going to be talking about a little bit with blood pressure and heart rate and what ECG is and what they're important for and who uses them and why use them. But the main topic of this conversation today is going to be cardiorespiratory fitness testing, or CRF testing, which is a way of measuring or estimating someone's VO2 max. All right, so this is something that's commonly done in sedentary as well as very active people, and it helps you prescribe exercise effectively for those individuals. So what I want to do here is have kind of a question and answer format for the first handful of slides, just because it kind of sets the stage a little bit here. So the first question is, what are health and fitness tests? All right, so basically health and fitness tests are a series of examinations that are going to look at the 5 components of health, health-related fitness, and potentially the 6 skill-related components of fitness. All right, so at the very least, you should have all 5 of the health components examined. So you should have tests for your clients for those. The 6 skill-related components, you can kind of give or take and choose which ones you think are most important for your client based on their goals, their age, and their assumed capabilities. All right, so some examples of health-related tests that aren't exactly fitness tests, because not everything that we are going to be talking about is an actual fitness test. A lot of them are just sort of health screenings. Something like a fasting blood glucose measurement or even a blood pressure measurement. Those are not fitness tests. Those are just health screening tests that most, if not everybody, should go through prior to exercising, at least if they're a little older. Make sure that they've seen a doctor at some point and had some of these tests done. Some of them you might be able to do yourself, but it's a nice way of screening for risk factors that suggest that they might develop cardiovascular disease in the future. All right, so the second question here, who should undergo health and fitness tests? All right, this one's fairly easy. Pretty much everybody should. Everybody who's a new client to you, who is generally healthy, who you don't perceive any reasons why they might get sick or injured from participating in these tests, those are the people who should participate. So that's, again, almost everybody. There are some certain situations where you wouldn't want to test people, certain clinical populations, but generally speaking, even if you think a certain test is not safe for somebody, there's probably another test does the same job that would be more safe for them, and you should just choose that test rather than not testing at all. Why perform health and fitness tests? So we perform health and fitness tests for a few reasons. The biggest one is so we can get normative data, well, compare them to normative data. So in other words, data that is matched for their age and their sex. And so it gives us an idea of where their strengths and weaknesses are and what they need to improve on most. So it's really good for doing that. And with that, you can establish a baseline. So if you do it before you ever train them and then do it after you train them, it gives you something for comparison within themselves so they can see how they improved, and that's going to help keep them motivated. It's also going to help you keep them coming back to you as a client, and it's just generally good for people to understand, are they improving, are they not improving? Because if they're not improving, that means something needs to change in their training. So if they're not getting better in the categories where they weren't so good to begin with, then again, that means the training isn't sufficient and you need to adapt it in some way. And then the third reason why people do health and fitness tests is to get some idea of their risk. So I already mentioned briefly, So a lot of these tests are things like blood pressure, where you're going to try to assess whether or not they're likely to have high blood pressure, so hypertension, and that's a risk factor for future cardiovascular disease. So a lot of times these tests are just geared towards finding out if they have a high likelihood of developing cardiovascular disease. And if they do have a high likelihood of developing cardiovascular disease, a lot of times that suggests that you should put more emphasis on the type of fitness where it's going to decrease the risk of cardiovascular disease. So basically aerobic type fitness. What makes for a good health and fitness test? So first off, it has to be accurate, it has to be reliable. If it's not a good test. All right. So if you can't get information that's useful, then why bother with the test? You shouldn't do it. The second reason here, or the second thing that makes it a good test is it suitable for the population that you are testing? So if you have an elderly client, they're probably not going to be able to do the same test as your 25-year-old highly fit client. So it has to be something that is not too hard, not too easy, and most importantly is safe for the client that you're working with. The third thing that makes it a good test or not is whether or not there's normative data out there for you to compare them to. All right, so sometimes you can get away without having normative data, just because, again, you can use these tests as a sort of pre and post test, so a baseline, and maybe 6 weeks or 6 months later test them again and show them their progress. But most of the time, you want to be able to compare them to other people that are like them, so age and sex matched individuals, and see what's their percentile rank. Are they at the 50th percentile, so average, or are they the 90th percentile, and maybe that's not something that they need to focus on so much, that component of fitness. Where vice versa, if they're in the 20th percentile and they're not doing so well in that component of fitness, then you probably need to put a little extra emphasis on that. Can you perform all fitness tests in the same day? So this one's, it depends on the test you use, but generally speaking, yes, you can. It's oftentimes good, though, to split it up over 2, maybe even 3 days if you're doing a lot of high intensity tests. Make sure that the tests you're choosing are non-fatiguing tests or are only mildly fatiguing. Let's say you're doing like a VO2 max or a VO2 max estimate test. Those are usually going to be fatiguing tests where the person's going to feel very tired afterwards, and it's going to be very difficult for them to do any tests after that where they aren't going to perform worse because they're just tired from a previous test. So you also want to, and this gets me to the next one, it's what's the appropriate order for performing fitness tests if you're doing several tests in a single day. So the ACSM doesn't have a specific recommendation list of which order tests should be done. So that, muscular strength first, maybe muscular endurance second, and cardiorespiratory fitness third, or flexibility tests first. It doesn't really give you that. It's got some very vague information. But what we're going to do is look at what the NSCA, so the National Strength and Conditioning Association, what they recommend, along with some additional recommendations that are just coming from me. And so they give a little more detail to the recommendations. So let's go ahead and do that now. If you're going to be trying to get to the information that is on this slide, you're going to want to get to this textbook here, the National Strength and Conditioning Association's Essentials of Strength and Conditioning. This is the QR code that will take you to information about how you can get that textbook and where you can buy it. But this is generally where this information comes from, with a little bit of alteration coming from my own personal thoughts. All right, so if you are performing all your tests in a single day, the first thing you need to do is any consents and waiver forms that you're going to do. All right, so I know it's not exactly a test, but you have to do consents before you do any fitness tests. Otherwise, you're increasing your liability, and they aren't informed on what the risks are of those tests, so that's not a good thing. Once the consents and waivers are done, the second step is going to be to get all forms filled out, besides the consents and waivers that had to be first. So any health history questionnaires, your PARQ Plus, exercise history, so you want to know how often they exercise, what kind of exercise, what the intensity of that exercise is. And then number 3 here, perform all resting tests. So these are tests that require no real effort on the participant. So things like blood pressure, resting heart rates, their height, their weight, their body composition. If you're doing any sort of circumference or blood pressure or blood tests, so if you're taking blood and measuring their resting blood glucose levels, something like that, you want to do those all before you bother exercising them, just because these are all non-fatiguing tests because they almost require zero effort on the client. Number 4 here, you want to perform a light warm-up. So again, this isn't really a test, but this is something you need to do before testing people, because if you don't warm people up, the risk of injury is much, much higher. Number 5, do the truly non-fatiguing fitness tests. So these are generally flexibility tests, so functional range of motion, so which kind of goes along with flexibility, balance, reaction time, coordination, those sorts of things. A lot of the skill-related components of fitness that we're not going to really be going over as much here. Number 6, do the agility and change of direction tests. All right, so you'll notice that I list both agility and change of direction. That's something that comes from the NSCA. ACSM does not separate them out into 2 different categories. That would just be agility if it was ACSM. All right, number 7 here, all the power and strength-based tests. So a lot of the resistance training or the resistance type tests are going to be done in this 7th position here. And generally speaking, these do have some fatiguing factors, but you're not usually doing a lot of repetitions. You're not usually doing a lot of sets. So people will recover quickly from them. So even though they get tired from them, they usually recover within a few minutes, 10, 15 minutes maybe, and then you're able to do additional tests afterwards. And the same goes with the agility and change of direction tests, at least for a young, healthy person. If we're talking about an elderly person, some of these tests are probably not tests that you would want to run. The speed test, so this is basically your 40-yard dash or something like that. This is a little bit more fatiguing than a typical muscular fitness test, but still not as fatiguing as the next one, which is your fatiguing anaerobic capacity test. So this is things like a Wingate test, so a 30-second all-out bicycle test. You're just trying to see how much energy your anaerobic pathways can produce and you utilize in a given period of time. And then the very last one is the cardiorespiratory endurance test. So the cardiorespiratory endurance test, we're talking more about the kind of tests that we're going to be focusing on in this chapter set. So your VO2 max test, your VO2 max estimation test. So a lot of these are going to be treadmill and bicycle based tests, or maybe outside on like a track or something like that. So there are a lot of purple tests and categories here. Those purple categories are ones where you don't always want to test them. So most of the ones that are in black here are ones that you're going to want to do all the time, except for maybe extreme situations. But for instance, if you're working with somebody who is 65 years old, all they want to do is increase or maintain their fitness in order to stay healthy and live longer, then doing a fatiguing anaerobic capacity test probably completely unnecessary. So these purple ones again are all tests that are unnecessary but might be useful in certain situations. In order to talk intelligently about cardiorespiratory fitness tests, we need to talk a little bit about metabolism and how our body uses oxygen, right? Because all the cardiorespiratory fitness tests, for the most part, are going to eventually get to a single number that is their estimated or estimated or measured VO2 max. And VO2 max essentially means how much oxygen you can consume. So we need to go over this little crash course slide here. All right. So first of all, we have anaerobic pathways and we have aerobic pathways. Anaerobic pathways are the pathways that make energy that do not require oxygen. So this is primarily, we're talking about the phosphocreatine system and glycolysis with this. And so these are the pathways that are going to supply most of the energy for high intensity exercise that's say a minute or 2 minutes in length. Once you start going beyond 2 minutes, you start getting into these next set of pathways, or the next pathway, the aerobic pathway. So the aerobic energy pathways are ones that do require oxygen. So this is the reason why we breathe, is so we can get the oxygen to these aerobic pathways. All right, so these aerobic pathways, we're talking about essentially one pathway that has 2 parts to it. So it's the Krebs cycle and the electron transport chain. And these also bring in substrates from a lot of other pathways, such as glycolysis, beta oxidation, as well as protein catabolism in some situations. So basically, we're talking about a lot of pathways that converge onto the Krebs cycle and then the electron transport chain. Again, we're not going to, this is just a quick crash course on this, so we're not going to go into these in detail. I do have a video online about bioenergetics, so I'll link to that below so that you can see that video. If these things sound completely foreign to you, you can watch that, it'll help out. the idea behind testing, so again, we're cardiorespiratory fitness, we're primarily talking about testing these aerobic pathways, not the anaerobic pathways. That was the anaerobic capacity tests, the ones I said were unnecessary for some people. So the aerobic capacity test is essentially looking to see how much oxygen your body can bring in, use to make energy, and then the energy be used up too. So how much oxygen you consume. All right, so that's what we call it when you bring it in and use it up. So how much oxygen you consume is the best indice we have in order to estimate or calculate someone's aerobic fitness or cardiorespiratory fitness. So VO2 is again a measure of how much oxygen a person is consuming, and generally we're talking about during a specific exercise intensity, whether it's submax or maximal exercise. And a VO2 max is the same thing, except for it's the measurement of that oxygen consumption when the person's working at their maximal intensity. All right, so VO2 max is the gold standard for measuring cardiorespiratory fitness. That's something I want you to try to remember. When measuring cardiorespiratory fitness, so again, that VO2 max that we were just talking about, or VO2 if we're talking about submax, there are essentially three types of measurements that are three different types of units on this measurement that are usually expressed. All right, there are others, but these are the most common. So we have what most people call absolute units. So this is going to be in liters of oxygen per minute of whatever activity they're doing. And so this is going to be very useful when you want to calculate something like calories burned, because 1 liter of oxygen consumed equals 5 kcals of energy. So it's very useful in calculating caloric need of an exercise bout. The next category here is relative units, and when I say relative, generally speaking, we're talking about relative to total body mass. So the units for this are usually milliliters of oxygen per kilogram of body mass per minute of activity or exercise. This unit is the one that you're going to see most of the time on normative charts when people are being compared to others of their same age, sex, whatever. And the reason why it's going to be listed on normative charts is this. So absolute VO2, the one that was just liters per minute, it is going to always be greater in the person who's got a bigger body mass, or almost always. So if you have somebody who's 200 pounds and really big versus somebody who's really small, like say 105 pound female, the big 200-pound person's always going to consume more oxygen on an absolute standpoint, simply because they have a larger body mass that has to be fed that oxygen. Where the smaller individual is always going to have the lower number. When you make it relative to their body mass, because all you're doing basically is you're dividing their absolute VO2 by their body mass, so you're dividing out the body mass from the equation essentially. You're then able to compare people who are at different sizes and weights. So now we can compare a really small person to a really big person and have a general ability to decide who is more fit from a cardiorespiratory fitness perspective. The last method for measuring, or the units for cardiorespiratory fitness expression that I want to talk about, is the MET. So this is the metabolic equivalent of rest. So I don't have the word rest there, but that's what it is. It's metabolic equivalent of rest. That's what the MET stands for, the actual letters. And basically all this is if you take the relative VO2 and then you divide it by 3.5, then you get a single MET. So if somebody is, say, working at 7 mLs of oxygen per kilogram of body mass per minute, that's 2 METs. So 7 divided by 3.5 equals 2. All right, so the usefulness of a MET, so let me back up for a second. A MET is simply how much oxygen a normal person uses at rest. So if you were to go and get 50 people into a room and measure how much oxygen they're consuming when they're just sitting there not doing any physical activity, they're all going to be right around 3.5 milliliters of oxygen per kilogram of body mass per minute. And again, this is a relative unit. So they're all going to be around that 3.5 level. So we generally just say, okay, that's one resting unit of energy. And so that's where the MET came from. It's one metabolic equivalent of rest. So it's always equal to 3.5 milliliters of oxygen per kilogram of body mass per minute. And so because most people rest around the same level of oxygen consumption, we basically can use METs, which is that resting level, in order to prescribe exercise according to factors of rest. So we can say, okay, work at 4 METs. That means 4 times as much energy consumption, aerobic energy consumption, as what you would do at rest. All right, so it's a very useful way of prescribing exercise, especially to people who want to do less traditional exercise, because there are these things called MET tables out there, and I'll be showing you some of those later in this class. And those MET tables basically list every possible activity you could think of, everything from gardening to sitting in a pew at church singing to walking your dog, to whatever you can think of, and it's going to list what it is in METs. So let's say you're sitting in a church singing, maybe that's 1.7 METs. And so you can then calculate how much oxygen consumption they are doing, or you can prescribe them to go sit in a church and sing, and they will know how hard they are working from a cardiorespiratory fitness perspective. You can also back calculate this with some other information about their weight and things in order to figure out how much calories they're burning from doing that activity as well. So METs are just a nice way of sort of converting back and forth between some things. And also for some people, it makes it a little easier for prescribing exercise. How is cardiorespiratory fitness testing useful? So I kind of talked about a few of these before. So it's useful for establishing a baseline for exercise prescription, as already discussed, so we know what your fitness level is now, so we can determine, okay, maybe you can do this much without it being too intense of an exercise. You can also evaluate the positive and negative changes in fitness over time. So again, we get your baseline, we test you again in 6 months, and we compare between the two. And it allows you to assess strengths and weaknesses and compare them to normative values, so we can figure out, compared to somebody like yourself, are you doing better or worse in this category of fitness or not? So some other reasons, though, to determine their physiological responses at rest and with exercise. All right, so especially for more clinical environments, it's useful to be able to determine, is the heart rate responding the way it's supposed to? Is systolic blood pressure responding the way it's supposed to? And if it's not, that's a sign that there might be an issue with the heart or with something else. And so this is something that's done all the time in clinical situations, but even in a fitness situation, you should be assessing things like heart rate and blood pressure when doing these cardiorespiratory fitness tests, so you can make sure that things are going appropriately and you don't have any causes for concern where you might want to stop the test and have them go get a medical checkup. All right, so along the lines of some of that clinical stuff, this is cardiorespiratory fitness testing is one of the primary tests used in clinics in order to look for things like coronary heart disease and other cardiovascular diseases. So this is done in what's called a stress testing clinic. Usually it's done with an ECG, so electrocardiogram, which is basically a test that assesses the electrical activity of the heart. The heart functions through its own electrical network, and so if the electrical network's not working properly, that means the heart isn't going to function properly either. So a lot of times, again, this is done in clinical settings, not so much fitness settings, but the test is the same as what you would do in a fitness setting. It's a VO2 max estimation or a true VO2 max test. So they just throw on the ECG and do a few extra safeguards, like have a medical personnel there to make sure things are safe or something like that. And also, establishing their current level of cardiorespiratory fitness will give you an idea of what they can perform in their everyday work and life tasks. So if somebody is very low fit, or maybe let's say somebody had some sort of incident, maybe they had a heart attack, and you need to find out, are they ready to go back to work? So oftentimes this, again, will happen in a clinical setting, but you would test their cardiorespiratory fitness in order to see, okay, their work, let's say their work in METs is maybe 5 METs. So they need to be able to work at least 5 METs before they go back to work, and they need to be able to do that without any weird physiological responses. So you see how these kind of all fit together. So you'd test them, you'd put them on a treadmill test typically, and you'd ramp up the protocol to make it more and more intense, and you would see if they were able to get past that 5 MET threshold by usually a little margin to make sure that they always stay within within a healthy range. And once they're able to do that, they would oftentimes get cleared to go back to work. So when you're testing people's cardiorespiratory fitness, there's some things that you want to keep in mind that are going to affect their abilities and that might change the type of test you're going to do. So obviously their age, talking about kids, young adults, middle-aged, and elderly individuals, those are all very different categories of people. A kid is not going to do the same fitness test as somebody who is elderly. All right, they're just very different in their cognitive abilities. Usually, if we're talking about young kids, it's a little harder to get them to understand and perform something appropriately and safely. So you're probably not going to prescribe, or probably not going to choose a test that's a little more difficult conceptually with them. But they have usually higher fitness levels than somebody who is elderly, so you might be able to push them a little farther. So that's going to affect the tests. Their estimated fitness level. So if somebody comes to you who is sedentary, who's never exercised a day in their life, they're going to get a very different test than somebody who comes to you who's a pro athlete or maybe a past pro athlete. They obviously their fitness level is going to be really, really high, so they can perform at a much higher level safely. All right, so this person is going to get the harder test than this person most likely. Their current health status. So if somebody is healthy, they pretty much can do almost any test you want. If somebody's unhealthy, let's say they're a cancer patient or a recent cancer patient, so they've gotten past all their treatments, that person is probably going to have a lower level of fitness because they may or may not be completely recovered from their treatment and their condition. And so you want to probably test them with something a little lighter in intensity. Keep in mind someone's cardiovascular disease status or their risk factors for that. So somebody who, let's say, recently had a heart attack, you're not going to want to make them do a maximal exercise test, a maximal cardiorespiratory fitness test in like your fitness center. It's a much higher risk test than what is necessary. You're probably going to do something on the low end of submaximal. Likewise, if somebody has let's say they are an obese person who smokes a pack of cigarettes a day and hasn't exercised in 10 years, then you're probably going to want to choose a test that might be a little safer, a little lower intensity for that individual. All right, then the last thing that you want to consider when choosing what tests to have for an individual is obviously the equipment you have available to you. So if you have a treadmill, you can use a treadmill. If you don't have a treadmill, you can't. So do you have an exercise bike? Do you have a metabolic cart, which is what you need in order to do the actual measurement of VO2 max, or do you need to do an estimate-based test? So these are all things that you need to consider when choosing your test and choosing whether it's going to be a true measurement or an estimate-based test. Cardiorespiratory fitness tests or aerobic fitness tests oftentimes come in one of these three types. So we can have, so looking at these quickly, we have time on the x-axis of each of these, and we have exercise intensity on the y-axis for each as well. All right, so this first one is a single stage test where basically you start, you're at the resting level of energy consumption, you go up and maintain that for the entire test. So this is something like, say, a Austrian bike test should be a single stage exercise test. Then we have other tests that are going to be a graded exercise test where it's going to increase in intensity every so often. Usually that increases about every 3 minutes. So you bump up the exercise intensity, you stay at that for 3 minutes, and you bump it up again, and you bump it up again every 3 minutes. So this would be something like a Bruce protocol or a YMCA bike test. Then we have ramp protocols here. There's a lot of them out there where basically, so it's usually called a ramp protocol. The exercise intensity goes up fairly consistently throughout, but usually what it is, it's every 1 minute or something you increase the intensity. So it's not truly a ramp. It's more like a very small graded exercise test. So as in the steps are very small, and so you go up every minute, small tiny increments every single minute, and so it gives it this sort of ramp like protocol when you graph it time or exercise intensity over time. So again, these are the three very common protocol types. So a single stage test, a multiple stage graded exercise test, or a non-stage ramp type protocol, which both of these are going to have increasing exercise intensity all the way to either a set time point or set criterion, or maybe all the way up to maximal exercise. So if you're going to do maximal exercise tests, so let's say you're going to do a true VO2 max measurement, you're going to need either a graded exercise test or a ramp protocol in order to do that. I would say probably the most common of these three is going to be this middle one, the graded exercise test. So let's talk though about what happens to your cardiorespiratory systems of the body during a test that's either a ramp test, which is what I have listed here, or basically a graded exercise test is going to do the same thing. It's just these responses wouldn't be so smooth; they'd be jumping with each ramp up. But basically, you're going to have an increase that's going to be linear. So by linear, I mean a straight line, kind of like what we're seeing here with the systolic blood pressure. Just kind of goes straight up. So you're going to have a linear increase in oxygen consumption, so VO2. You're going to have a linear increase in cardiac output, which is how much blood the heart pumps in a minute. You're going to have a linear increase in the heart rate, which is how many beats your heart does in a minute. And you're going to have a linear increase in systolic blood pressure, the one that I just showed you here, which is the blood pressure in your arteries, your body, when the heart is contracted. All right, so you're going to also have an increase in several other variables. Some won't increase, at least not with cardiorespiratory exercise. So for instance, the diastolic blood pressure typically stays around where it was at rest during a cardiorespiratory fitness test. So as long as they're not really pushing their muscles and contracting muscles really, really hard and forcefully, you're probably going to see the diastolic blood pressure stay about the same regardless of their fitness, regardless of the exercise intensity. All right, so it can come down a little bit, it can go up a little bit, but if you were to average this over a few people or a few tests, you probably see very little change in diastolic blood pressure. Diastolic blood pressure is the blood pressure in the arteries between heartbeats, so during the relaxation phase of the heart. All right, so stroke volume, we have this depicted here, is going to have this linear increase until about 50% of your person's maximal oxygen consumption, so 50% of their maximal ability, and then it's going to kind of level off in most people. In elite athletes, this isn't going to happen. It's going to just keep going up until almost the end. But in most people, it's going to level off somewhere between, say, 50%, maybe 60%. And stroke volume, I forgot to say this, stroke volume is how much blood comes out of the heart in a single heart. Then we have pulmonary ventilation, which is how much air is coming in and out of your lungs per minute. And this is also going to increase linearly at first, and then it's going to increase at a much faster rate once you pass what's called the ventilatory threshold or the anaerobic threshold. So at a certain point in time, you start blowing out a lot more because you're trying to expel extra CO2 that's built up from lactic acid in bicarbonate, from the bicarbonate pathway. We're not going to really go into that in detail, but again, you should look into that if it's unfamiliar to you. All right, so these are all things that are going to increase with a ramp or a graded exercise test. They increase with a stage test too, but they increase and then kind of level off and stay at that level because that single stage test, because you're only going to go up one stage and then and your exercise intensity levels off. So these are all going to be tied to your exercise intensity. So if exercise intensity goes up, these are going to go up. Let's talk about some contraindications to fitness testing. All right, so an absolute contraindication is something that means you definitely should not be testing that person. So if somebody has an absolute contraindication, that means do not test them until they are medically cleared. This is going to be coming primarily from the ACSM guidelines textbook. So if you scan this QR code here, you'll see the textbook I'm talking about, so you can purchase that if you don't have it. But hopefully you already have it. If so, please open it up to box 5.2 so that we can go over this together. All right, so I'm just going to quickly go through the list. You have it in front of you in your textbook, so I'm not going to say every little thing here, but I'm going to talk on the majority of them and sort of tell you what some of the words mean here, because it's probably a little bit unfamiliar to you. So if somebody had, these are all, again, absolute contraindications, meaning you should not do exercise tests if these are present. So acute myocardial infarction. So in other words, a heart attack that happened recently, and it's within the last 2 days. So if you're testing somebody and they say they had a heart attack a day ago, you should not be testing them. So cancel the test. So unstable angina. So this angina means chest pain. So this means you have chest pain, and because it's unstable, that means it's happening at random times. So at rest, or it's just completely unpredictable. So some people will have chest pain that is stable, meaning it's predictable. All right. So if you have chest pain every time you get to 5 miles an hour on a treadmill, and then it goes away as soon as you stop exercising, that's stable angina. That's predictable. If it happens at rest, if it happens when you get a little excited, if it happens sometimes when you start walking and not other times when you start walking, that's unstable angina. That's much more dangerous, and so that is a absolute contraindication. So uncontrolled cardiac arrhythmias. So this is something that is only going to be important when you have what's called hemodynamic compromise. All right. So in other words, if you have an irregular heartbeat, or heart rhythm, and that irregular heart rhythm is going to decrease the amount of blood coming out of the heart to the point where you start having symptoms, that means you're not getting enough blood to the body, you're not getting enough oxygen to the body, and that's a potentially dangerous situation, so you don't want to test them either. So if somebody has current endocarditis, so this is an infection to the inner lining of the heart or of the valves of the heart, and so this is something that is very dangerous and you should not be testing somebody during. If you have symptomatic aortic stenosis, so severe aortic stenosis, so this means basically you have some sort of issue of the aortic valve that's causing symptoms. Often this is something related to heart failure, so the person who has this isn't going to be able to get the proper amount of blood out of the heart into the body. Oftentimes they'll have backwards blood flow as well. The aortic stenosis causes, again, an improper amount of oxygen to get passed out to the body. If somebody is in decompensated heart failure, so this means that they have heart failure, so again, they're not able to get enough blood out to the body as they should, and that their body isn't able to compensate for that. In other words, a lot of people have compensated heart failure with maybe their heart rate will just go up a little bit, and it allows them to get enough blood flow to the body. Decompensated heart failure means even with whatever compensatory mechanisms their body is trying to use, they're still not able to get enough blood to the body to support normal functions of daily living or light amounts of exercise. So you shouldn't exercise these people without very close medical supervision. If you have, or the person has any sort of embolus in their pulmonary system, so in other words, they have some sort of blockage of blood vessels in their lungs, this is something that you should not test them during. Also, a deep vein thrombosis, so if they have a blood clot in a deep vein of their legs, their arms, whatever, this is something that can break loose with if the blood flow is sort of hitting it a lot. In other words, if you're exercising, your blood's flowing strong, it can knock off a part of that clot, and that clot can travel to the heart or to the brain and cause a heart attack or stroke. So that's the reason why you don't want to test somebody that has a deep vein thrombosis. Acute myocarditis or pericarditis, so this is just inflammation of the heart, so swelling of the heart, typically with some sort of immune response. So this is dangerous. It can hurt the heart if you exercise them during this. Aortic dissection, so acute aortic dissection. This basically means that the aorta, which is the main artery that carries blood flow to the body, if it has sort of a ballooning out of one side of the one of its walls, so this is basically a weakened wall of the aorta that's stretching in an abnormal way, and if that were to burst, the person's going to bleed out pretty quickly. So if you increase their exercise intensity, it's going to increase how much the blood flow is being pushed through that, and it's going to increase the pressure on that dissection, aortic dissection, and that could cause it to blow. And if it blows, they're probably going to end up dying from that, so you don't want to test them. And the last absolute contraindication here is any sort of physical disability that precludes them from exercising in a safe way or following your directions in a safe way. So if somebody has they're mentally incompetent in such a way where they can't follow your instructions or it would be dangerous for them, Or if somebody has just an illness, an acute illness. So if somebody has the flu, you shouldn't exercise test them. That some people can find they get into very serious situations if they try to exercise when they have something like the flu or pneumonia or something like that. These are acute infections that you just have to wait until they're gone and the person recovers, and then you can test them. But while they are still sick, you should not be testing them. Those are absolute contraindications to exercise testing. So we also have relative contraindications to exercise testing. An absolute contraindication means you do not test them almost under any circumstance. There might be a few very, very rare ones where somebody else needs them tested for a very specific clinical situation, but generally speaking, you're not going to test them ever. A relative contraindication means you need to use some of your own judgment of whether or not it's safe to exercise them. And whether it's safe to exercise them is dependent on the severity of the situation, your preparedness, your education, your skill level with that specific syndrome or condition that they have, and your availability, what's available to you. So do you have a cardiologist right there, or are you completely on your own in like a YMCA? All right, those are very different situations. The cardiologist is going to increase the level of risk that you can take because they are capable of dealing with emergency situations that you are not. Likewise, you have a crash cart there in case somebody were to drop with some sort of cardiac arrest. If not, you probably don't want to do testing during some of the things that I might talk about here. But the point is, you need to determine what the level of risk is, what your ability to respond to an emergency is based on your skills, your availability to other people who have skills, the equipment that's available to you, and also the necessity of the test. If somebody's coming to you just to get in shape and they have one of these, you may not want to test them. You might want to just start them at a really low level of exercise and slowly build them up, and do it that way rather than test them and get them right to a more appropriate level of exercise for their fitness level. So you don't always have to start somebody off at a high level or even a moderate level. You can start them very low and slowly progress them if necessary. All right, so let's get to these relative contraindications. And again, for this, you're going to look at the ACSM guidelines textbook. So go ahead and again scan the QR code here in order to see that textbook and know what I'm talking about. And this is going to be box 5.2. All right, so if they have left main coronary stenosis, so this is a narrowing, oftentimes a hardening of the left main coronary artery of the heart. So that's the one of the big arteries that feeds the heart, so the heart gets oxygen. If that is narrowed, then that means a higher likelihood of a heart attack, so you might not want to test them. Again, might not. These are relative contraindications, not absolute contraindications. All right, so moderate to severe stenosis, with an uncertain aortic stenosis with an uncertain relationship to symptoms. So in other words, they have aortic stenosis, so they have some sort of abnormality to their aortic valve that's probably a hardened valve. It probably doesn't open properly, probably doesn't shut properly, but you don't know if it actually causes any negative symptoms or consequences for the person. Then you might want to think about whether or not you should test them. Oftentimes you're going to want to find out some medical information before choosing to test them or not. If somebody has a tachydysrhythmia or with uncontrolled ventricular rates. So a tachydysrhythmia, that just means an irregular heartbeat that's really fast. All right, so a really fast heartbeat that's going to affect the ventricles, the bottom parts of the heart that actually pump the blood to the body. All right, so if the bottom parts of the heart that pump the blood to the body are squeezing too quickly, that can decrease the amount of blood that gets to the body and decrease the oxygen that gets to the body. So this may or may not be something you would want to test them during. If they have some sort of acquired or advanced heart block. So heart block is something you would find out by doing an ECG, so electrocardiogram on the person. And so advanced level, we're talking second and third degree AV blocks, so atrioventricular blocks. And this is something that can be there at birth or it can develop later on. So it's something that that's where it becomes acquired. So if it's an acquired and advanced heart block, then they probably have an irregular heart rhythm of some sort, or they do occasionally have one, and it might get worse with exercise. You might not want to test them. If they have a complete heart block, that means there's a complete disconnect between the top and the bottom of the heart. You probably don't want to test them unless you have very close clinical supervision. If the person had a recent stroke or something called a transient ischemic attack. Okay, a stroke just is basically like a heart attack, but in the brain. So lack of blood flow to an area of the brain, potentially causing death to brain tissue. Transient ischemic attack is kind of like a mini stroke. It comes on with the symptoms of a stroke, but then it goes away and it has typically no long-lasting effects. So if they have a history of that, and they are currently or have in the past had some sort of symptoms, you may or may not want to test them. Anybody with a mental impairment that's going to make it hard to give them direction, have them follow that direction, depending on the level. Again, we kind of talked about this before. That was in the absolute contraindications. When I was talking about that, I was talking about somebody who just could not listen and follow directions at all. In this case, I'm talking about somebody that's a little impaired, but can follow some level of directions and cooperate in some degree. So you need to decide whether or not you can reach them and have them understand you and have them follow what you're asking them to do. If not, you probably don't want to test them. If they can follow, it's just a little more difficult. You need a little more verbal guidance, or maybe even pictures to guide them. Then you might be able to test them. If they have a really high resting blood pressure, so we're talking greater than 200 millimeters of mercury for systolic and greater than 110 millimeters of mercury for diastolic blood pressure, that's increase the likelihood, because the blood pressure is going to go up with exercise, especially the systolic. It's going to increase the likelihood of having some sort of cardiovascular event during that increased blood pressure. Any sort of uncorrected medical conditions. So this is kind of your catch-all category. Things like anemia, which is a lack of sufficient blood cells to carry or hemoglobin to carry oxygen around the body. Electrolyte imbalance, which imbalanced electrolytes can mess with how the heart functions as well as how the muscles function. Hyperthyroidism, so in other words, your thyroid gland produces too much of the hormones that increase metabolism. This can cause a lot of side effects that can affect someone's ability to exercise safely. So any of these, again, are relative contraindications, meaning you need to make a decision whether it's safe for them to exercise and safe for them to have exercise tests done on them in your setting with your level of skill and capabilities. All right, so now we're going to talk about, let's say you've gotten past all the absolute relative indications for not testing them. So you're doing an exercise test on somebody. Now, let's say something happens or some symptom shows up during the test. The list I'm going to give you here are indications for stopping an exercise test once you've already started the exercise test. So we again have absolute indications for stopping, meaning if one of these happen, you stop immediately. And we have relative indications that mean if they happen, you can sort of make a judgment call, again, based on the safety of the situation, whether you should stop or continue the test. And so a lot of these are going to require you to do blood pressure measurements during the test and or an ECG, so electrocardiogram. So if you're not doing electrocardiograms, which you're not going to do in most fitness centers, you might not even know some of these are happening. But you should still do blood pressure assessments even if you are doing these tests, cardiorespiratory fitness tests in a fitness center. All right, so again, here is the QR code to get to the website that's going to show you how to buy the ACSM guidelines textbook, but hopefully you already have it. So let's go ahead and open up to box 5.4. That's what I'm looking at now. All right, so absolute contraindications, these are going to be some ST segment elevations. So if you don't know what I meant by that, you need to probably go and study electrocardiograms a little bit. So basically it's the flat line between the main complex that is the ventricular contraction and the ventricular depolarization and the ventricular repolarization, the T wave. All right, so that flat segment there, it is elevated greater than 1 millimeter of mercury, and it's persistent, and it's happening in a handful of different leads, then that's something that you probably don't want to test anymore, so you should stop the test. So these are absolute indications for stopping a test here. So if you have a drop in systolic blood pressure, so remember, systolic blood pressure should rise continually with exercise intensity. So if blood pressure goes down, even though you've increased intensity by 10 millimeters mercury or more, then you should probably stop the test. If you have moderate to severe symptoms of angina, so chest pain, you should stop the test. If the person is dizzy, they experience ataxia, syncope. So basically, syncope, we're talking about blacking out. These are all signs that there's bad blood flow through the body and affecting the blood flow to the brain. All right, so if blood flow to the brain is low, you're going to get dizziness, you might black out, those sorts of things. So if those happen, stop the test. Other signs of poor perfusion to the rest of the body, so cyanosis, which is basically like a blue tint to the fingertips or the lips maybe, and pallor, so this is paling of the skin. Those are signs, again, of poor perfusion, in other words, poor blood flow to the body. A sustained ventricular tachycardia, or some other sort of irregular heartbeats. You can read the rest of those in your textbook yourself, but they have to be something that's going to affect the cardiac output during exercise. So in other words, it's going to decrease how much blood flow is getting to the body. Any sort of technical difficulties with your main measuring equipment. So if you're doing a stress test in a clinic, so you have an ECG going and the ECG machine stops working, or if you're measuring blood pressure, which you should always be doing, even if you're in a health fitness center, and your blood pressure cuff breaks, you should stop the test. Because if your safety equipment breaks, then the test is going to be more dangerous, and so you shouldn't continue. And the last indication that's an absolute indication is if your participant or your client ever asks to stop, you should always stop. They're always in control, so if they ask to stop, stop. Those, again, are the absolute indications to stop a fitness test during the fitness test. The relative indications for stopping a fitness test during the fitness test are these ones. So ST segment displacement, the same segment of the electrocardiogram I talked about before. So again, this is only when you have an ECG going. That is horizontal or downsloping. And so basically we're talking about a decrease in the ST segment. This is something that may or may not be something you want to stop the test for. A drop in systolic blood pressure of 10 millimeters of mercury or greater, despite the fact that you're increasing exercise intensity. Again, so I didn't mention on the last one, I should have, that drop when in the absolute indications was when you have some sort of sign or symptom suggesting that there's not enough blood flow to the body. This is if there's no sign of lack of blood flow. So in other words, the other one, maybe they're getting lightheaded or dizzy and they're having a blood pressure drop, definitely stop the test. This is their blood pressure's dropping, but they don't feel anything else. They feel completely fine. Then you can make a judgment call. A lot of times when that happens, that's just because you had an improper blood pressure measurement, and you probably just need to retest the blood pressure, and then you'll notice that it's more accurate the second time. All right, so increasing chest pain, so in other words, increasing angina, fatigue, shortness of breath, wheezing, leg cramps, claudication, so typically cramping of the calves, it's a cramping of the calves, sign of peripheral arterial disease. Any of those are, again, relative indications of stopping a test. Any arrhythmias that are sustained but maybe don't interfere with the body's ability to get blood flow out. So again, you probably need ECG in order to see these things. An exaggerated hypertensive response. So in other words, their systolic blood pressure goes above 250, or their diastolic blood pressure goes above 115 millimeters of mercury. You should probably stop the test, but it's a judgment call again. If they have bundle branch blocks, so these are the electrical wiring essentially to the bottom part of the heart. So if those develop during exercise, you should consider stopping. Or the last one here, you're going to need a pulse oximeter to do this. If their blood oxygen levels get to equal to or less than 80%, you should consider stopping the test. Let's talk about the different types of cardiorespiratory fitness tests now. So oftentimes you'll hear people talk about lab tests and field tests. A lab test is something that requires a lot of equipment and basically has to be done in a laboratory. Field test is something that requires minimal to no equipment and can often be done outside on a track, maybe in a basketball court, indoors, or something like like that, where again, very little equipment. Those are the kind of tests that you probably experience in phys ed class growing up, or that you might have done as part of like an athlete on a sports team or something like that. Field tests are also done a lot of times in fitness centers. All right, so it's important to note that just because it's a field test doesn't mean it's submaximal. There are maximal field tests, and there are also submaximal laboratory tests, so that it can go both ways. But both of these are used to establish either an estimated or a measured VO2 max level. If possible, if you have the skill, if it's safe, you have the equipment, measured VO2 max is always going to be better than an estimate. So any measurement is always going to be better than any estimate of any kind of anything. So just keep that in mind. All right, so let's talk about the pros and cons to field tests. Pros, they do have a decent correlation between the results of field tests and the results of a true measured VO2 max. So that just means that they're fairly reliable and valid, and you shouldn't feel bad about using them. It is a good test, in other words. They oftentimes use a type of exercise or a form of movement that the person's used to. So there are, say, walking field tests, right? So people are typically used to walking around, but they're not usually used to running or cycling or something like that, at least not sedentary people. So it does allow them to do an activity that they are more accustomed to, because there's so many varieties out there. You can kind of pick one that fits them. There are also often tests that can be done in large groups. So again, I mentioned phys ed classes and sports teams oftentimes will use field tests because a lot of them don't require one-on-one attention. So cons here, it's difficult with field tests to measure physiological changes, so things like heart rate, blood pressure, actual VO2 measurements, because those all require sort of individual attention and equipment in order to measure. You also have to estimate. I already mentioned estimation is never as good as an actual measurement. So you can't measure the VO2 max without equipment, so you are left to just estimate, which again, like I said, there's a decent correlation here, so it's not like it's a terrible thing, but it is something that has some error because of the estimation. And also, a lot of times these are done outdoors, which means the weather can be a problem. So if it's a rainy day, if it's icy outside, if it's extremely cold, extremely hot, it's going to affect the accuracy of the test, and you probably want to consider whether or not the test should be run that day. So some common field tests here, the Rockport 1 mile walk test. So this is that walk test I was talking about, where you basically walk a mile around the track as fast as you can, you measure your heart rate. Pretty easy test to do, and it can be done in large groups as long as everybody knows how to measure their own heart rate. The pacer tests, these are tests that basically people usually do on a basketball court. You might have done this in a phys ed class at some point in time. You run back and forth touching different lines in the court, and there's a beep every time you touch a line. And every time the beeps get faster and faster and faster, and you have to go back and forth until you can't keep up with the beats anymore. That's the pacer test. The Cooper 12-minute run test, so this is just how far you can run in 12 minutes. The 1.5 mile run test is how quickly you can run 1.5 miles. And then the YMCA step test uses an aerobic step, and it's just a fairly low level test as well. This is another good one, kind of like the Rockport 1 mile test. They're good field tests for people that are probably lower fit. Let's talk about laboratory tests a little now. So as mentioned before, they're usually graded exercise tests, which means typically every 3 minutes the intensity goes up and up and up and up. And so it is a progressive test. It can have submaximal stopping points, so maybe they stop at 85% of maximal heart rate, or they can go all the way up to maximal exercise and be a true max test. Oftentimes in clinical situations, these are going to be symptom-limited tests, which means you stop the test when the person has some sort of abnormal sign of disease or dysfunction. Maybe they get chest pain at a certain level, and then you stop the test at that point. And oftentimes they'll do that knowing they're going to eventually hit chest pain or something, so they can try to figure out what level of exercise they can work at safely. When doing these laboratory tests in the United States, usually you're going to see people using treadmills for these tests in labs. If you were to go to a lot of places in Europe, you'd see a lot more leg cycle tests, so in other words, exercise bike tests. Both of those have pros and cons to them. So let's talk about the leg test first. So first of all, it's very easy to measure heart rate and blood pressure during a leg cycle test because they're not moving their upper body that much. It's also very safe for people who have issues with balance. The cons to leg tests is usually the person is going to have leg fatigue before the rest of their body fatigue, so they're going to stop the test earlier than what they would have on a treadmill most of the time. Another difficulty is pacing the individual, so they need to cycle at a certain RPM typically in order to make the test accurate, and some people can't seem to cycle at a consistent rate, and it's very difficult for them. Most of the time, if somebody is doing a leg cycle test, that pacing I was talking about, they are going to need to maintain 50 to 60 RPMs or 70 to 100 RPMs depending on the type of test, and oftentimes depending on whether they're a competitive cyclist or just a normal healthy person. Also, because they're using a smaller amount of muscle mass on a leg test than say a treadmill test where the whole body's involved, their VO2 is going to typically be lower. So if you're actually measuring VO2, you're going to see lower levels than if they were to be on a treadmill. All right, let's talk about treadmills now. So most people are very accustomed to walking, so treadmills are very comfortable for them because they're walking on the treadmill too. They're highly reproducible because unlike the cycle, the leg cycle ergometer, where you have to tell them, try to stay at this rate, follow this metronome, or look at the RPM on the screen or something like that. With a treadmill, you just set the speed and the grade, and all they have to do is keep up. It's very easy for the test to be reliable in the methods. The cons here, if somebody holds on to the handrails, which a lot of people tend to do because they just feel a little unsteady on a treadmill, it can make them seem like they're higher fit than they actually are because they're holding themselves up with their hands rather than having to propel themselves with their legs the whole time. Treadmills oftentimes are more expensive than leg cycle ergometers, and then also treadmills, people fall all the time on treadmills. Usually it's because they step on one of the side rails or they kick the front of the treadmill. Occasionally people will fall off the back of the treadmill just because they get too close to the back, but people fall all the time on treadmills. It's very hard to fall on an exercise bike. When you are doing treadmill testing, I just want to mention this, the most common protocol is something called the Bruce protocol, and that's going to be in most clinical situations what you're going to use is the Bruce protocol. During graded exercise tests or any sort of cardiorespiratory fitness test, you're oftentimes going to measure these things here. So you're going to measure heart rates, and if you want to learn how to do that, I have a link here and a QR code you can scan. You're also going to typically measure blood pressure. Again, here's the link and QR code, and then also ratings of perceived exertion or RPE, and here is again the link and QR code to learn how to do those measurements. All right, so heart rate is typically going to increase about 10 beats for every MET increase in exercise intensity. So the heart rate is something that you should probably measure every minute or at least every stage during the exercise bout. You're typically going to palpate the heart rate for 30 seconds or for 15 seconds and then do a calculations to get it into beats per minute. So if it's 30 seconds, you're going to multiply by 2. If it's a 15-second palpation, you're going to multiply by 4. Blood pressure, you're talking about getting systolic and diastolic blood pressure. And systolic blood pressure should also raise about 10 units, so 10 millimeters of mercury per MET of exercise intensity, where diastolic blood pressure shouldn't change a whole lot during cardiorespiratory exercise. So ratings of perceived exertion or the RPE is something that basically the client tells you how they're feeling. It's a nice way of getting an idea of how hard it feels for them. We do have a couple different ratings of perceived exertion scales. So we have the classical one, which is the 6 to 20 scale, the Borg scale, which is still probably the most common in most educational classrooms or clinics out there. And then we have the category ratio 10 scale or the CR10 scale, which goes from 0 to 10, which is a little more common, I'd say, in fitness centers or in certain clinical settings. And the reason for this one is 6 to 20 is if you add a 0 to each of those, so 6 would be 60, 20 would be 200, it's supposed to mimic the increase in heart rate of a young, healthy individual. All right, so it's supposed to be an idea of, give you an idea of how high the heart rate is, which goes up with exercise intensity. It's not great at that. You probably shouldn't use it for that, but it's still a useful scale to get an idea of how hard they're working. So very light intensity exercise, you're talking 6 to 8 on the original 6 to 20 scale, or 0 to 1 on the CR10 scale. Light exercise would be 9 to 11 and 2 to 4. Moderate intensity, which is where most people are going to work, is 12 to 13 on the Borg 6 to 20 scale and 5 to 6 on the CR10 scale. Vigorous intensity exercise, which is what most highly fit people are going to work at, is going to be 14 to 17 on the 6 to 20 scale and 7 to 8 on the CR10 scale. And then once you get to 18 to 20 on the 6 to 20 scale, or 9 to 10 on the CR10 scale, that now you're at or near maximal exercise, and most people aren't going to want to work out at that level for very long or ever, potentially. So you're not going to see that quite as much. One note I want to give you about RPE before we move on: make sure that the person knows that, well, two notes, I guess. One, that they need to progress through. So make sure that they know when they're up in this range, they're basically at rest, they're not doing anything. If they're telling you these numbers during exercise, they're not using the scale appropriately. Help them, give them some guidance, and make sure they're progressing their numbers as the exercise intensity increases. The other note I want to say is this is supposed to be full body exertion that they're giving you a perception of. If they're saying my legs are really hurting, they're 20, that's not really what we are trying to get at here. We want to know total body, how do you feel? So your legs might be working really hard, but maybe your breathing is just fine. You're not a 20 if that's the case. So make sure that they're giving you a full body feeling of exertion. Again, go watch the video that's on this QR code here to get a little more information on how to use the Borg scale. So just a couple miscellaneous notes here about exercise tests, specifically graded or ramp tests. So sometimes it'll be a test to find out functional capacity. So functional capacity is the highest amount of oxygen a person can use, where the heart rate, the blood pressure, the ECG, and whatever else is being measured, the responses are still normal. So they might be able to work out at a higher level, so it's not maximal exercise yet, but they are to a point where their physiology is misbehaving. And so basically a functional capacity means the person can work out at this level or less and be healthy and safe doing so. So a lot of clinical environments will try to come up with someone's functional capacity, not necessarily their maximal capacity. All right, so when the other sort of miscellaneous notes here, when doing one of these maximal exercise tests, you really want to have them hit their max somewhere between 6 and 12 minutes. If it's shorter than this, so if it's too short, it's typically more of an anaerobic test than an aerobic test, especially if it's less than 2 minutes. And also the increments of the intensity. So if you're doing like a graded exercise test where every 3 minutes you're increasing, that means the increments were too much. The person couldn't get to their actual max because they probably, let's say the first workload is really easy. The second workload, which is if it's a every 3 minute test, the second workload's too hard, so they end up stopping, 3.5 minutes into the test, so they're 30 seconds into the second workload. That means their actual capacity was somewhere between here and here, and you didn't test them anything between this. That means that you missed their actual maximal aerobic ability because you went from too easy to too hard because your workloads were too big of a jump. And this can oftentimes actually happen with the Bruce protocol that I mentioned was a popular test. The jumps are pretty extreme. A lot of people stop. You don't actually hit it. So sometimes a ramp protocol is better for figuring out someone's actual maximal capacity. All right, so on the other end of things, so if it goes much more than 12 minutes and the test is too long, they're probably going to get tired and exhausted and stop because they're tired, and not stop because they've hit that specific place where they're at their maximal ability. So again, too short is not good, too long is not good. 6 to 12 minutes is the ideal range. A lot of times when doing VO2 max estimation from submaximal tests, what you're going to be using is heart rate in order to do the estimation. And a lot of times what you're going to see is they're going to need the heart rates, the ones used to estimate VO2 max, to be somewhere around 110 or greater. and also less than 85% of the max heart rate. And there's a reason for that. First, there's two reasons. One, you don't want to go much further than 85% because most cardiovascular incidents that are going to happen during exercise are going to happen beyond 85% of their maximal heart rate. So if you're going beyond that, the risk level is higher. So it's even though the risk level is still low for most people, it's an unnecessary increase in risk. So most people try to stay below 85% to avoid those risks. But the other reason, and probably the more important reason, is heart rate tends to be linear during that range. Linear meaning a nice straight line. So below that, it's a different slope. Above that, it's a different slope. So it becomes a little less predictable, and it's harder to get a good estimate of max when it's not predictable. So between 110 and 85% of their maximal ability is usually where people are going to take the measurements in order to estimate the VO2 max from. So I mentioned heart rate max. Best way to get someone's heart rate max is to actually have them exercise until they can't go any further. So go do a max test and simply measure what their heart rate is when they can't go any further. But most of the time, again, this isn't going to be something that's necessary or healthy for them to do or possible for them to do. And so the next best thing is to estimate it based on their age. And so the most common formula people use is 220 minus age to get an estimated heart rate max. There are other equations out there. One of those is 208 minus 0.7 times their age. And there's several other ones like this that are slightly better as far as accuracy than the 220 minus age, but only slightly better. And 220 minus age is so common and so easy to remember that most people just use this. And generally speaking, I do too. I just think it's a more user-friendly equation to try to memorize and use. When doing cardiorespiratory fitness tests, a lot of things are going to affect the accuracy and the comfort of the test. So here's a short list of those things that you want to consider. So what's the temperature and humidity that day? So right now, today, it's 90 degrees, high humidity. So you probably don't want to do an exercise test outside during that. It's not safe, and the exercise test results probably aren't going to be that good because they're just going to be overheated. How much sleep did they get the night before? So were they up late studying for a test or something? If so, their exercise test isn't going to be very valid either. Their emotional state. So maybe they're suffering something in their personal life and they're very depressed or sad in some way or upset. Their emotional state is going to affect the validity of the test and their ability to sort of motivate themselves to work hard in the test. Hydration status. Are they dehydrated? If so, dehydration is going to negatively affect their test. What medications are they on? There are medications that do affect exercise capacity, beta blockers being one of the most common ones you're going to hear about because it prevents the heart rate from going up. So those are going to affect exercise capacities to some degree. The time of the day, is that first thing in the morning when they're still stiff and tired? If so, probably not going to get an accurate measurement. How long has it been since their last meal? Some people need to have a little food in their stomach. Some people can't have any food in their stomach. So if somebody who can't have any food in their stomach, you don't want to test them right after lunch. Nicotine use. So in other words, do they smoke? If so, that's going to affect things because it might affect their ability to breathe heavily during the test. Caffeine use. So caffeine can be a little bit of an ergogenic aid sometimes, which means it can make it easier to do well in the test, but it's not saying that you should encourage it. You should encourage them to do things in a very standard way for exercise tests. So I would suggest no caffeine before tests. Any previous exercise. So, are you going to do a graded exercise test right after they do heavy squats? Probably not, because their legs are going to be very stiff and tired and sore, and they're not going to be able to perform very well. And then anything in the psychological environments around them. So is there music playing? Is there a TV in front of them that's distracting them? Is somebody trying to talk to them? Are they trying to look good and, instead of working hard, they're more worried about how they look in the gym, that kind of thing. Anything like that's going to affect their ability to perform well in the test. So these are all things you need to keep in mind and potentially try to mitigate in order to get accurate measurements during a cardiorespiratory fitness test. All right, so that was an overview on cardiorespiratory fitness testing for health and for exercise prescription. So there's a lot of information there. Make sure you take some time and really study it and look through those textbooks I mentioned. There's really good information, some of which I probably didn't go over here because it's just too much to go over in a single lecture. But if you have any questions or comments, you can put those in the comment section below and I'll try to get back to you on those. Otherwise, please come back and watch another video. Thanks.